the mic should work straight through here through the live stream. It usually has like a 10-second delay, so.
There's a 2-second delay. Yeah, but are they able to hear Riley?
Yeah, I'm going to speak through the mic, see if they could see the screen as well as the video.
Audience and the voice from Riley.
Let's see if that comes through. Are they on it in the back?
I don't know.
Oh. Oh, do you want to?
Able to hear the audio on the
Okay. Riley, do you want to go test with here? Do you want to speak? I'm going to go test.
Yeah. Now, delay is fine for people who are way back there, so that's okay. I mean, they're not here, so delay is okay. Riley, are you able to? Huh? Oh, it's not them. Okay, so I thought you were talking to them.
No, I'm talking to.
Oh, okay.
Increase the volume to the thing.
Let's see if I can find the YouTube link.
Is there a volume control here for mics? Yeah.
Well, then it would go for the entire place.
Upstairs also?
Or in ours, like
It's okay. A little more should be okay. I mean, then.
in the closet.
Oh, okay.
We go into here, and we'll go to settings.
Not on the valley. It's west coast. Oh, so didn't miss Dyson?
I don't. You got me.
It's all right. It's all right.
Hello, hello.
So, Astha.AI, a legendary
Hello. It's Max, right? So, yeah. How's the audio? It's Max on our end. Yeah.
It's Max on
In the broadcasting side of it. Yeah. So,
so are you able to hear it now?
Muthu, just send me the link for the YouTube channel now, or where. Riley, do you have the link? I'll go check it out. Yeah, can you just see? Yeah? Are you able to hear me? I think she's that's working because you can hear the.
It's showing our wrong slide.
Oh, okay.
This was like long before they hire you. This was like this was when they were thinking. So
On the computer on the Max volume or the audio?
You want to increase the volume on the audio volume speaker? Which window capture are you looking for? Screen mirroring, okay.
well worn tennis shoes. Billionaire. And yeah. So anyhow, I know at one point, by the way, that's the more video. That's the actual. So I watched them, and everybody starts showing up in t-shirts. And so I turned to Esther, who I know slightly. I guess I should take biology. Yeah, I think it's about time.
Yeah.
It was like very patronizing. Like oh, it's so.
I think it's Max there.
Interesting because I was on the panel and even eventually Cleveland Current came up. Friend saw the research. She goes, you know,
That's fine.
we don't do ties to the thing test, and walked off, and I was just like, oh, I got it. Like I got. You know what? It's like ties are.
Yeah, that's fine.
I'm going to make it bigger here in a second.
Oh, refresh. Okay. Yeah, but are you able to hear? Yeah? Testing 1, 2, 3. You should be able to hear me. Okay. So any of those mics should work, right? I mean, we're going to be giving it to all of them. Okay. All right.
Do you want to talk at the same time? Just test together just to make sure.
Yeah.
Maybe we'll do like,
Hello, hello.
Yeah,
Check,
so-
check, 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 check.
oh,
Hello, 1, 2, 3.
make sure you're using normal voice. Don't keep it too close.
Oh, okay.
Because that's when it starts to cut out. So like probably like 2-3
Hello.
inches, normal voice.
Hello.
Make sure the other presenters know that as
Okay.
well.
Yeah.
Probably both sides can share a mic.
Yeah.
Two
I think
mics
two
out.
mics, one mic each side.
Yeah. Yeah, well, one mic each side. I think that'd be perfect. And just, yeah, normal voice. Once you start talking too loud, it cuts out. Yeah,
It's already on.
Yep. So the live
Who's getting the first question? You are. If I'm first, then I'll hold the mic.
Yeah, you should be the one.
I'm gonna go find a screen clicker.
Okay. They've got 4 mics. We should be passing the mic. Yeah. Because that way we can argue more flawlessly.
I don't need a mic. I think it's...
No, but I think
Hello, hello.
Yeah.
Hello guys, we're gonna get started now. Can you guys have a seat, please? Yeah, we have a panel now, and a small presentation. We have a lot of seat up here. Please come and join. You can go a little bit ahead if you want. Oh, perfect. You wanna go down? Yeah, if you don't mind, let's go that way, please. Yeah. Hello guys, if you don't mind, let's go there. We are starting now. Yeah. Thank you. Thank you. You should go. You guys. Yeah, let's have a seat and we'll have network down the road, like once the panel is done and everything.
Don't want to be greedy.
Oh, no.
Hello.
I'm gonna hit you up.
Okay.
Yeah.
Loaded with pizzas. Please help yourself. Yeah. Thank you, folks, for coming on a Friday evening. And a lot of it's been streamed online. A lot of folks are decided to do online because of the traffic and whatnot. thanks for coming up in person. We are a team from Kencor Health. I'm CEO of Kencor Health, Muthu Krishnan. And we are a health tech company based out of Palo Alto. And our teams are all spread over across the country. And short overview about Kencor, then we'll get into the panel. We have a very, very interesting topic, AI in healthcare, how it benefits the patients and how it benefits the physicians. Okay. Kencor is a HIPAA secured SaaS platform that is pioneering the healthcare technology, dedicating catered to the transforming the ways healthcare is delivered and experienced. So it's a patient engagement platform. It's connecting the last mile delivery of patients and the providers is what Kencor is. By doing this, we integrate with all the wearables. We integrate with vital devices. We integrate with all the EMR, EHR systems, and we provide that AI driven insights to the hospital team members so that they can work on the patients who are in need in terms of red, yellow, green zones. Next slide. The problem we are facing is $5 trillion in the US spent in healthcare, and it's growing. And the trigger for that is a fragmented care and also more of a reactive than a proactive care. So that is what the healthcare system problem today. We have experts in the panel to talk about in depth when we get into the panel. So Kencor market opportunity, we looked into this opportunity in 4 buckets: physicians, health systems, payers, and the ACOs and the other groups. So AI ML, which is a topic today, is one of the way we addresses to all the mundane tasks of the patients, the care team members will be using our AI technology. So we are cautiously using AI because it's a patient care, and we'll talk about it in length later during the panel. I'm not going to get deep into our solution, but we have value-based care product like remote patient monitoring, chronic care management, remote therapeutic monitoring, PCM, principal care management, and TCM as part of our offerings. And it's more of a proactive monitoring, what I talked about, personalized care plan, seamless integration, and value-based care is the saga, what we are trying to do, and all the projects under BBC. The impact, this is one example of how we are able to detect the readmissions. This number is really 52.4 billion in US for the hospital readmissions, 3.8 hospital readmissions per year. The readmit in healthcare, there is a famous term called U-turn. So if you're going for a CHF, getting admitted, you come back for the same diagnosis or same admit, it's called as a readmit. So one readmit costs $18,000 for a 4-day stay in a hospital, right? So our Kencor platform, we have a paper, 40% reduction in avoidable readmissions. In other words, is $7,200 savings per readmit is what our platform does, right? Oh. Oh.
Very subtle.
You're kicking our panels? Good point, though. Good point. Good point.
Thank you.
Sorry. Are you able to say it? We are all coming from JP Morgan Chase conference from the city, so you make us to walk. That's good news. The last point for the providers, say for example, you have a neighborhood clinic. It can bring around 240 to 500K revenue for just enrolling 500 patients in the clinic, right? So we have 64 clients, hospitals and clinics, so they're leaving money on the table. These are all Medicare reimbursable payments. The last one for patients, our platform act on at 92% patient engagement, never heard before. And one quick example of that is we have saved, our care management saved around 15 patients every quarter in terms of with the vitals showing high or low, and they are able to call the 911 and physicians like Dr. Asif at the right time to know about this patient is already admitted in the ED, right? Today there is no system doing that unless the primary care doctor goes and visits. My patient is there on the ED or hospital. We'll talk more about the agentic AI workflow. We take the vitals, variables, CMR data, early risk detection, personalized care plans, and the intelligent engagement. What we do, some of the use case, early warning ML, personalized AI nudge. So that means we know our care management team can say, okay, these are the predictable patients who are going to take vitals today. So they know they can act on it, right? So that's the AI nudge we use on the AI engine. The last one, the dashboards. This is one of the main focus for everybody. People like Mayo and other folks want to integrate because they don't have this dashboards of what Kencor has. The last one, which I touched on it, our agentic AI doesn't replace physicians. I'm sure John and Dr. Asif appreciates it. It's going to be complementing them, giving the insights of their patients. Next slide. This is a study. If you're interested, reach out to our product team to get more into. I'm not going to spend too much. This is 2,000 patient study in the rural part of Central Valley in California, and we have done it for 1 year. It's a fantastic paper. We are going to publish it shortly with AHA, and Dr. Asif Ali is going to talk about it. These are some of our customers. Few of them on the left, you can see all the logos. 3 things to make a note of it. 92% patient engagement, 8 out of 10 patient stickiness score. That means the patient love our platform because ease of use, and they can spend like 7 minutes a day in our platform where all the vitals and questions have been reported seamlessly. Any questions from audience before we go into the panel? Okay. Can we get in the panel? Yeah.
Don't worry, no more slides.
So we'll go through the panel topics, and we can reserve the questions for the late so that we can address all the panel workflows, and then we can address it. But if the panel decides that it can be interactive, we can do that also. Ready? All right. So I'm Muthu, the CEO of Kencor Health. I will like each of the panelists. Dr. John Mattison, veteran at Kaiser, ex-CMO. He's in the board of Kencor Health. He's one of the board of directors at Kencor. We have Dr. Asif Ali. He's a CMO who joined recently. In fact, from January 1st of 2026, he's already here. I'm proud to announce Dr. John and Asif Ali. And Arjun is my friend here. He's having a fantastic AI security company in the Valley. So let's go start with you, the introduction, then we'll get into the panel.
So welcome everybody, and looking forward to this conversation. AI is becoming the most disruptive
invention in human history, perhaps since the invention of fire, and it's changing everything. So my background, I was an evolutionary biologist, marine biologist before I went to medical school, practiced in 7 specialties, drafted to lead the digital transformation at Kaiser Permanente, got very involved in data standards and interoperability, and started the machine learning / AI group at Kaiser Permanente now 19 years ago. And so AI has been part of my pedigree for a long period of time. And I used to go to conferences where people would say, oh, it's all hype, it's overhyped. And there's something called Amara's Law that says that futurists tend to predict too little too soon, too much too soon, and too little down the road. So we're on the cusp of absolutely revolutionizing everything about healthcare through AI, and I mean everything, including robotic surgery is going to explode. The self-service, direct-to-consumer AI is going to explode. And there's a lot of concern that while we're putting more physicians through residency programs right now to make more active physicians, that AI is going to unburden a whole lot of what happens in our healthcare infrastructure. So we're all about to witness a movie like no other disruptive technology in the past, and predicting how far and how fast it's going to go is very difficult. So I like to bring a sort of a futurist perspective to just how disruptive the change is that lies ahead, and part of what Kencor Health does in terms of giving patients more control over their health journey is a very essential aspect of how AI is going to enable a very disruptive transformation in healthcare.
Thank you, sir.
Thank you, Muthu, for having me out, and Kencor. I'm Dr. Astha.AI. On the academic side, I'm a clinical assistant professor at University of Texas in the Texas Medical Center in Houston. I'm also an adjunct professor at University of Houston, and I'm the director of CNET Research Institute, where we actually look at a lot of these wearable devices in AI and beta test. More on the commercial side, I've been in about a dozen startups. I was both public and private companies like Fitbit, and on the, I guess, venture side, Modi Ventures is one of the organizations that I'm an advisor to. To add to what John was just talking about, not only that this technology of AI came out, but it's also the fastest to get adopted across the spectrum of people. Look at ChatGPT. Interesting enough, I have a number of interns from universities and medical students and residents, and I asked them, put your hand up if you have one of the LLMs on your phone and that you're paying for it, not the free version. And everyone put up their hand, and I was just shocked because students don't have money, but they're willing to spend it when they see value. And the value that they're seeing is amazing. And another, just to add to John, we're in an inflection point of the utopia and dystopia. We're going to go down a certain pathway, and it's the people who are involved in making those decisions can really turn us one way or another. So it's very important that we have KOLs, we have people in the room to be part of the discussion, to make sure the subject matter experts are driving this and not just corporate America.
Thank you, sir.
Hi guys, I think few of you have seen my face more than enough. I'm a co-founder for Astha and also a co-creator for Safe MCP. What does that really means is working with other folks from open source community to normalize the attack vectors around agents. There is not a consensus language how we can really codify how agent can be attacked. And just to kind of give an interesting analogy, just to kind of put that in a perspective, is think that you have you wanna have animals like pet, and you have two kitten, like very small kitten, and you realize that one is kitten and another is cub, like super small, right? So when you think about it, in a year, the cub gonna go really big, you're gonna be a tiger, and you're gonna have a kitten gonna be really small. I mean, and you come back after a year, if you have a kitten, I mean, it might, give you some claw, you'll be fine, but the tiger might eat you. So that's the thing. That's where the attack difference between agent and the regular software is about. So when we treat agents just like other softwares, then you might just like get in the enterprise and just like you might end up in Wall Street Journal headline at the wrong headline as a big company. So that's where we are really trying to normalize what are the possible attacks it could happen in the agentic code. And yeah, I feel fortunate to be part of it.
Thank you, sir. Thank you.
Sure.
I think let's get into the panel. I think the first question is to, not in a particular order, but with Dr. Ali. Can you briefly explain what AI in healthcare encompasses and the different applications we currently use in the industry?
That's like an hour lecture right there, but
All the
AI in
questions are going to be
healthcare,
like that.
but yeah, that's okay. So it's a very open-ended question. So I think the first statement is to make is we're at an inflection point where technology, clinical science, and value-based incentives must align. And we have the ability to do that now. So the question is really AI in healthcare really refers to the application of advanced computational methods, right? So particularly like machine learning, deep learning, natural language processing, we know about that. But to add to that, this is to augment clinical decision making. And you talk about it, about the kitten and the cub, we have to remember we're making clinical decisions on patients' lives. This is not, this is patients' lives at risk, so it's patient-centric first. We always need to keep that. I mean, we talk about the human in the loop. The human here is making clinical decisions that can have outcomes. And if you don't train your models correctly, there can be terrible consequences, and we'll get into that. I think at the patient outcome is really what we're looking at. And just kind of 6 bullet points that I look at in AI in healthcare because it's a very broad topic, but if I were to break it down into a couple of bites, clinical decision support and diagnostics. Number 2 is predictive analytics and population health. Operational and workflow optimization. This really is what reduces the churn for him and me, not to have physician burnout. And it's not just physician burnout, it's the entire system, the nurses, the support staff, and I want to recognize them. And then what Kencor does, which is remote monitoring and digital biomarkers for early clinical escalation and decision making. And then personalized and precision medicine and patient engagement and health equity, which is close to my heart because you can't have good outcomes if you don't have adherence. And how do you get people to buy in to a system? You have to create behavioral change. And that means you have to have data that's actionable. And I believe that's what Kencor is all about.
Thank you. Don, I think this will be very close to your heart. How do you believe AI can enhance patient care and improve patient outcomes? You can quote a few examples. I know you've done loads of examples, but please.
So again, that's a very, very broad question, and almost any aspect of AI in healthcare can generate an hour of discussion. But suffice to say that the early implementation of AI in healthcare is really around operational optimization. It's safer, it's easier, it's more reproducible, and you can get to good results fairly quickly. In terms of how we improve the patient experience and in terms of how we improve patient outcomes, that's a lot more complicated. Because if you look at sort of the frame of this session is around how physicians and patients experience it. But there are really four sort of categories of players in healthcare: those who pay the bill, those who provide the care, those who receive the care, and those who look out for the public health of the larger community. And each one of those segments is optimized for a different outcome. The payer wants to get the most value for the population under their care and maintain costs. And in the not-for-profit world, to have a sustainable business model. In the for-profit world and the fee-for-service world, it's how to return revenue to those who provide the capital for the operations. In the provider's world, what you want to do is you want to do the best you can with the resources available to you for every single patient you see. From the patient's perspective, you want to get the best possible care that's available to anybody, anywhere in the world. And from the perspective of public health, you want to simply optimize value in terms of health outcomes and longevity, health span and lifespan, for the population under your purview. So those are slightly, each one of those are a different set of objectives. And so you get what you incentivize, and design always must be faithful, so form follows function, and each of those four functions are not the same. And so what I see happening with AI in healthcare is that there are going to be many different providers of AI solutions that are optimized for different players in the system. And people talk about agent swarms. There are already enterprises outside of healthcare that have thousands and thousands of agents in operations today. And there will be many, many more in healthcare because it's so much more complicated because it embodies the entire human experience. And so when you think about how different providers of these agentic AIs and whatever the next generation of AI is provide them, you have to really have an understanding of what is their objective and how are they going to achieve it. And how does the design of those agents achieve that goal? And Jensen Huang, the CEO of NVIDIA, in his keynote just less than a year ago, said that he sees that every institution is going to need an HR agent that just monitors all of the agents in the swarm to make sure that they're adhering to the ethos and the principles and the values of that institution in their role. Well, there's a problem there. And that is that there are these four different aspects, at least. There are many more subsets of those. And so how do we reconcile, and this has been a human problem to date, it's not a new problem, but as we start automating these conflicting agendas with agents, how do we have insight? So he's proposing that we have an HR agent. And when I heard him say that real time during his keynote live stream, I thought, an HR agent? There's going to need to be hundreds of HR agents, and there's going to have to be a meta HR agent that monitors all of the HR agents, and there's going to have to be a human and a team that has oversight to really constantly validate. So coming back to one of the things that Asif said earlier about how we think about the human in the loop and the curation. There was a paper published in JAMA, the Journal of American Medical Association, about 2 years ago, written by several pathologists from around the world, and they claimed we're really headed into some very treacherous territory here, because as AI gets so good, because an AI reading pathology slides can have the benefit of having read millions and millions of slides and coming up with a good result. And yet there's not a human pathologist alive who's reviewed a single million slides. So how do you maintain a cadre of pathologists who is competent and capable to curate when you're going up against an AI infrastructure and agent swarms that are looking at the same pathology slides? Same is true for radiology, same is true for every diagnostic and every sensor in healthcare. And so we have some really challenging problems about keeping the human in the loop. And so the simplistic way, and we have to be reductionists here because it gets more complex than the human brain can wrap itself around, we need to be very mindful of how we focus first and foremost on the transparency of the values that are being implemented, because we're not going to be able to outthink these AIs that have memorized hundreds of millions of slides and mammograms and on. But how they translate that analysis to your individual mammogram or your individual pathology slide of a biopsy, and what's the value set that is represented by the recommendations that come out of that. So there's a lot of work that lies ahead of us in terms of understanding what we're getting into. And the last thing I'll say is it's been observed by many people in the field that implementing these agent swarms is a little challenging, but it's very doable, and lots of institutions are doing it in multiple vertical markets, inside and outside healthcare. Unwinding that and switching out from one provider of the agent swarm you're using to another is going to be a nightmare. And we're already seeing this with electronic health records. There's a collapse of the health record field down to really 2 or 3 providers into an oligopoly, not a monopoly, but an oligopoly. And we're likely to see the same thing. And if that collapse is based upon financial and economic considerations rather than the ethos represented by those, we're going to be at a loss to understand what's actually happening.
John, one question for you is that keeps me up at night, is if you implement an LLM in a hospital setting and it's training on your hospital and it's getting very specific, and that company goes bankrupt, what do you do?
Exactly. And that is going to be something that people should be writing into their contract. And the classic answer to that, because it's already a problem with large-scale software, the classic example is you put the source code in escrow, and you have access to source code. Well, having the source code to Epic, for example, or Cerner, or any of the major healthcare vendors, you need all the engineers at Epic to translate that source code and to operate on it and to improve it. So that model is already broken. So we're not going to fix that model. And the other thing I would say to that is it's even worse, because LLMs don't even begin to service healthcare, because LLMs are basically the distillation of large text strings. And in healthcare, we have images, we have labs, we have time series data, we have all the panoply of different kinds of data types that it must operate on, and just simply using iterative analysis of large data sets is not going to get us where we need to go. We need to have foundation models that are not based on text, and not based on images, and not based on lab slides, but based on fundamental biologic principles. So we need to have foundational models that actually have intelligence in the models. So what happened was I was the founder of one of the most widely used interoperability standards in healthcare, using XML. And the thing that's cool about XML is both data representations and an underlying model. When you go to LLMs, the underlying model is kind of inferred by operating and training on huge data sets, but it doesn't necessarily reflect the best science in the field. IBM tried to do that with Watson and failed miserably, because they looked at academic papers that were no human curation for the first 3 years. I told them it was going to fall apart because of that, and it did. But then they introduced human curation, and they didn't account for the fact that the 2 institutions they chose to do the human curation were very fee-for-service motivated. And so fee-for-service has its bias of revenue, maximize revenue as opposed to maximize outcomes. And I said, you're going to fail because of that. You need to give me the authoring tools in order to be able to create the algorithms that optimize for health, not for revenue, and let me own that piece of it. But now that we're getting into agentic AI and agent swarms and HR agents and so forth, it is going to be a big challenge. So your question of if they go bankrupt, what do? You better be thinking about that when you write the contract, and you better have a backup plan to manage exactly that. We have that in large institutions in healthcare today. We have, it's written in the contracts that we have a safe source that we can roll back to of the code if there's a problem, and you kind of get locked into that. But you also need to have an understanding of just how difficult it is to unwind something that is so deeply involved in operations that you can't simply turn it off and turn something else on. So these are questions that have to be answered. So while I agree with the techno-optimists that the future is very bright and giving patients much more authority over their own health, I totally subscribe to. But their timeline, following classically Amara's law, they're predicting it's going to happen too soon, and they're not really understanding the challenges and the complexity of supporting operations, and what if the vendor goes bankrupt, and what if you have two different agent swarms that are in a Darwinian battle with each other to survive. And as a recovering evolutionary biologist, there is no one in evolutionary biology that looks at what's happening in AI today and doesn't say there's going to be the same Darwinian survival of the fittest and competition and zero-sum thinking in the AI world as there is in the biologic physical world. And hence, most of the pioneers in AI are very concerned about how we manage this. So there's no stopping it. Let's just say there's no stopping the progress of AI. But how we approach it, how we engage, how we're mindful of these kind of landmines along the way becomes increasingly important.
Thank you, sir. Appreciate it. My takeaway is having the source code in the escrow. Thank you. That's a good one. I learned something today. Arjun has been waiting patiently, so let's get into the security of the AI for a minute. Then the question to you, Arjun, is how should healthcare organization balance the use of AI? Very interesting topic with patient privacy and ethical considerations. And after you, I would like both of you to address on that, because you have a lot more to say on that too.
Yeah, I want to kind of connect the dot about the escrow here, and I want to walk that a little bit more. If you think about the agentic mess, when you have a lot of agents, right? Because now what we are really thinking is we will have the assisted doctors, right? They will be like machine doctors, so to say, right? And one of the few of the customers we are kind of trying to help out, the big question from CISOs they are asking is, what if it's a human, I could see this X-ray as a human doctor, and I could see another X-ray, and I know that I cannot get this information trying to mess up with another X-ray information, because those are two different patients, right? How does the AI would know? AI doctor would just look at this, and in a split second would look at another report, and at the time how it can actually in the you could put a guardrail that, hey, this guy cannot have access to the other one, but it's a guardrail on the memory. So the guardrail on the context you need to think about, right? It's like saying your friend who is very talkative, right? Hey, keep this secret, right? And then he is very, or she is very talkative, right? He or she gonna go somewhere and say, hey, I'm gonna tell you this, don't tell anyone, right? And then they're gonna silo, that information, and it's like one guy knows, two guys know, and three guys, and at the end, entire village knows, right? So that is one of the problems when you go in hospital or anywhere in organization that gonna happen. When you bring agent masses, then what happens is they have this the power of decision making. That means they are not very deterministic. They don't follow rule. They deviate rule, and they try to get, if they have incentivized for something, they'll try to figure out a way to get that incentive, right? So this one thesis, like I have been kind of like really refining, is called the culture, agent culture. Just like the organization, when you think about organization, if it's a very healthy organization, that means the culture of the organization is healthy. That means people, the water cooler conversation is about innovation, not about backtalking or backstabbing. So those kind of small conversation becomes the culture of the company. So if you think about the agentic culture, what is the technology we need to kind of really think about so that we can create that agentic culture. So that when the agent is, it's like guardrails we have right now, right? You put all those logs and all those things, those are the guardrail for current software. But when there are this new software coming, we need a cultural guardrail. So those are like around the incentive, like why. It's like, why I'm an agent and why am I doing this? You start might be asking those questions, right? Yeah, so we need to really think. I think right now, we are working on the governance and security of agents. That's the first important thing we really think about is like the intent. How can you put guardrail around the intent? And when you have an agent mesh, it's not about guardrail on one agent intent. It's like a 30 agent trying to make a decision. And how can you put that deterministic, like a guardrail around the intent? I think that's an open question, and also in the industry, people are trying to figure out. There is nobody has figured out. Everything has been cracked, right? So it's a very open question on that one, I would say.
I love the term guardrail. So I was in Washington, D.C. for the American Heart Association on ethical AI. And the inherent problem is, and I'll just call it out, I mean, we still have biases, whether it's racial biases or gender-specific males versus females. So the problem is AI is not biased. We are biased. It's taking the human biases and it's just putting it out there. So first, if you don't recognize that, then it's a non-starter, at least for me. And so I've been in multiple forums like this, and really my concerns are the people who are creating the LLMs, if they have a political bias, say they're right-wing, or if they have a racial bias, or they have any bias, so who's training the models? That's one thing. And as a consumer, you don't have transparency. You don't get to go look. Let me tell you how important this is. I published a paper at the American Heart Association last year on wearable devices. The wearable devices, you guys wear digital devices, green, red, and infrared. And I did a study over 500 patients on cuffless calibration-free blood pressure detection using PPG, plethysmography, across various skin tones. They're called the Fitzpatrick scale. So we looked at 1 to 6 is the scale. So 6 is the darkest skin tone in humans, and down to 1. And what did we find? So if you remember during COVID, there were pulse oximeters that were sold in this market in the US where darker skin tone people wore those pulse oximeters that was checking your oxygen, and they weren't studied in Fitzpatrick 5 and 6. So the darker skin tones were not looked at. What is the consequence? People died. People were hypoxic, their oxygen was low, but the models that were created did not include those people. So my point was, if you're going to sell to people of color, you better have included them in your trials. And that is my concern about the LLMs. You cannot talk about and by the way, this is common in research where most of the cohort is a 65-year-old white male. And you as a consumer are going to take a medication and you're a 20-year-old African-American female. You were not studied in that. And forget about subcontinent Indians and Pakistanis and Asians. They're a really small minority in most clinical trials. And that is a fact. So then the problem is, if you're going to create an LLM and sell it to the masses, have you been inclusive? Have you looked at biases? And who's making those decisions within the company? That is a big concern. That should be something that consumers are not going to look. There's no transparency. You do not know if that LLM applies to you, but yet it's being sold to you. I have a problem with that. I think you need to call it out. And I think we have to hold the companies as responsible as a drug. You have medications like pharmaceuticals that are out there. There's inclusion-exclusion criteria, and we have to hold these LLM models because they're making decisions on people's lives. And we prove that in hardware that it actually caused harm. And we published that data, and it caused some discourse in how industry needs to be at a level of ethical framework. And I talk about ROV before ROI, return of value before the return of the investment.
John, any?
Yeah, if I could add just a couple of quick notes. So with respect to guardrails, and we talked about this before the panel, there are several published papers where agents have figured out how to work around guardrails because they were just in their way, and they behave like humans in zero-sum competitive thinking, and they defeat guardrails. So that's already well shown. The second thing is with the Fitzpatrick scale, an even earlier example is with the early dermatology pathology readings. People at the higher with darker skin were getting underdiagnosed for malignant melanoma, and they were dying as a consequence of reassurance that they didn't have melanoma, when in fact they did because of the training database. So to your the final point is to your suggestion of how do we have transparency into what the biases are. This is doable, and this is something that will evolve, but it will only evolve when people are intentional and deliberate about the following solution set. So every individual is unique. Even identical twins are not the same person because their DNA is shaped and up and down regulated by what they eat and what's in their microbiome and what they breathe and what medications they take and their whole life experiences. If you haven't seen Three Perfect Strangers, the movie about triplets that were adopted out, and they were this is like the most unethical study ever. They put each one of them deliberately in a lower socioeconomic, a middle socioeconomic, and an upper socioeconomic group to see what happened as a fun experiment. They didn't even tell them that they were part of a triplet in an experiment. They had no idea until they discovered each other when one of them went to college, and all these girls came running up to him and assuming that he was his unknown, one of his triplets who had gone to the same college the year before. And so no two people on this planet are alike. So the applicability of a particular infrastructure to a particular AI infrastructure to a particular individual is not just about the match between what it was trained on and that individual, it's use case specific. And so if you're looking at someone who may be of African descent for a renal cancer, it's a very different relative match than it is if you're looking for, say, an arrhythmia. And so it is actually context, the specificity of the match between the training data set and that individual varies by disease state. So this is a tractable problem, but only if we try and solve for it. And so some of these techno-optimists that are saying in 5 years, we're not going to need doctors, we're not going to need surgeons, we're going to have robots teaching robots how to do better and better surgeries with the software and the hardware evolving independently of any human thought, that's where this timeline becomes very treacherous, and that's where Amara's law comes in, because it's going to take a whole lot longer than any techno-optimist is going to say it's going to take to address these pitfalls and landmines that are everywhere. And they pre-existed AI, but AI just accelerates their exposure, accelerates their impact, and provides a whole lot less traceability and transparency into what's actually going on.
Thank you, John. One question, very interesting question to Dr. Ali, then I want to make it interactive, so make it open to the questions, then we can continue and wrap up. Is that okay? Right. Asif, what advantage does AI offer to the healthcare professionals in terms of workload, decision-making, and patient engagement?
So I'll throw 3 terms to you guys, and I've been populating this because this is the only way I can answer this, because I'm always about patient first. I mean, it has to be patient-centric. It's not about us. It's about the patient. Patient always is first. So I look at these 3 terms: pre-engagement, engagement, post-engagement. That's the continuum of the patient. Before they see the doctor, when they see the doctor, and after they see the doctor. So in the pre-engagement, I work with a company called First HX. First History, we take an SMS text to you, you fill out an AI algorithm, and it creates 60% of my note, puts it in my EMR. We created some filters for guideline-directed medical therapy, social determinants of health, inclusion, exclusion for clinical trials. So we filter, because I'm collecting data before you even see the doctor, I can filter a lot of stuff before you see the doctor. Now I'm seeing the doctor. So that's engagement. Engagement, what we commonly talk about is ambient listening. And that, I think, has been, I think there was even one in Kaiser that did a study. I still have to do the history taking. So it doesn't really reduce my time, but it at least gives me an opportunity to look at the patient rather than the computer the whole time, which is a very disengaged way of doing it. And we're forced to do that because the EMR is the only way for us to interact with you. And it's a terrible way for us to communicate. I mean, we've lost that communication. That's why we do telemedicine, so often. Can't even engage. So that's engagement. And then post-engagement is what we call remote patient monitoring, CCM, chronic care management. And to me, that post-engagement is so important because look at the average time a patient gets to see a doctor. We have RVUs. You get 10 minutes, maybe one time a year, and at the most for CMS, every 3 months. So you get what, 40 minutes in a year, and we're supposed to provide optimum care. I mean, you're talking about, you're just putting out fires. There's no, prevention. God forsake, like we can't even, you don't even have time for prevention talk. So we know that your zip code is your biggest determinants of your health, by the way, right? Where your zip code is. Because do y'all know there's something called a cardiology desert? 50% of America lives in a cardiology desert, which is defined as an hour round trip to a cardiologist and back. And if you live in a cardiologist desert, your mortality rate and your cardiovascular risk, rather, it goes up by 31%. So and that's a cardiology desert. There's food deserts, there's all sorts of deserts, and we know that. So where you live really determines your outcomes of your health. So you cannot change the outcome of a patient unless they have adherence. And how are you going to get patients to adhere? You have to talk about behavior change. And you have to be able to talk about health equity. And we're going to digital health. So now you need to talk about digital health equity, which is a different thing. How do patients interface with all this stuff that we're trying to collect data? At the end of it, MD means medical doctor to you guys. MD really means make decisions. And the only way we can make decisions is having data. But it needs to be actionable data. And so the pre-engagement, engagement, post-engagement, getting the stickiness, getting patients to adhere, and meeting the patient at their equity level and their digital health level and their health equity level. These are all really important. I tend to find companies don't do that first. They just push out products without really making the patient-centric and understand who the patient is and the behavior. It is so nuanced and it is so complicated. That's why there's just not one agent that answers all the questions, and I agree, it's not happening overnight.
Thank you. By the way, RVU is relative value unit. That's how the physicians get paid, if you want to know about RVUs. Let's open the questions to the audience, and then we can continue and wrap it up. Is it okay? Yeah. Anybody have any questions?
In the very back row.
Hey, thanks for all the talk. So this is about how do small startups with so much of regulation in health do all the data gathering and research to make the LLM more effective when even big companies are not able to do it. I feel like the regulations are just going to get more complex. If there is no competition for big companies, how will we, get innovation?
Yeah, it's a great question, and it's a really troubling answer. Okay. So the answer is that you can't compete with companies that have access to massive amounts of data when you're trying to build a foundational model. So you're going to have to rely, I mean, this is a natural oligopoly of where there's going to be a few survivors that have access to large sets of data. That's why there's this incredible race to have market dominance in LLMs, and LLMs are not the final solution by any stretch. Agentic AI, and there will be a next generation after agentic AI, that it makes it hard to compete. So if you're a small startup in healthcare, the advantage you have is that most of the large models are not using foundational models that really reflect the biology of human health or the behavior of human health. And one of the things we haven't talked about here, we need to bring into this, is that patient-centric is one thing, but person-centric, where we look at all of the aspects of the social determinants of health, have a bigger impact. How we eat, how we sleep, how we exercise, and how we build a community of support, and that we live within a community where we find value and meaning, have a bigger impact on health in the entire healthcare system. And there have been many different lenses placed on that issue. So those issues are there as well. But back to your question of, you want to do a startup in healthcare, you want to have it be AI-based. Are you going to go for broke and become the next big hyperscaler with data? Probably not. That market, start off with $100 billion and maybe you'll get there. But there's not a lot of startups that have access to $100 billion to do that kind of training. So the place that I think you compete is in solving specific use cases in the workflow scenario, in specific cases in the foundational model for a specific disease type, foundational models that address the complexity of the social determinants of health. And the best you can hope for, honestly, is that you'll carve out a persistent niche for yourself, or you'll be acquired by an aggregator of multiple solution sets like yours that build incremental foundational models. The problem is, even with the LLMs, OpenAI was essentially reverse engineered in China for a lot less money than the original curation of their foundational model. And that is a hazard of being a small startup in healthcare AI. I am not saying don't do healthcare startups in AI. That's not my message. My message is, if you're going to compete, you need to figure out how to define a specific market where your foundational model has unique value to, by itself, freestanding, or as part of an acquisition exit process down the road.
And I want to be very practical about an answer for you, because I've done over 15 small health tech companies, and I will tell you exactly how we did this. One, partner with hospital systems, because they have the data, and if you have a solution that they're looking for, they will give you access to that. Number two is, there's very large organizations like the American Heart Association that have the largest registries for put whatever disease that is, pathology. If you're answering their questions, say it's a rare disease or amyloidosis or HATTR, things of that nature, and you have a solution for them, they're like, yeah, we're trying to find this needle in the haystack. You have the solution. Larger organizations will connect to you. I'm on the health tech advisory group for the American Heart Association for Center of Health Tech Innovation. I meet with startups all the time. Come talk to me. I can plug you in there. There's vehicles to, if you're answering the right question, to get you into those data sets.
Yeah, I want to amplify one of the things you said, Asif, and that is that if you identify a problem that may have affected yourself or a family member or a friend that's motivating your startup, and you want to solve that problem, think about who's going to use your solution and go talk to them and say, here's the problem I'm trying to solve. Here's the way I'm thinking about the solution. is this a problem that's a priority for you to solve? Because if you can't find a product market fit, that the problem you chose and the solution you chose to that, you need to find a new solution that solves a problem they want to have solved. So there are way too many startups that fail because they solve a problem that nobody wants to purchase.
I mean, John and I could go all night. Yeah. One more point on that. AI, having the subject matter expert and a KOL to ask the right question is so important to get that person on early. And then that whole academia to commercialization, go to market, is what he just said. I mean, like, you have to talk to experts, not only on the academic side, but also on the commercial for viability.
I have one comment on the data part. I think sometimes you can think different. I'm going to give you an analogy. So, for example, if you are building a kind of cultural audio, like LLM, right? Think about that. That is very different and also kind of characterizes tone and everything of various different culture. I mean, one of the way you could really gather data is just create a kind of agent and call all the restaurants in America, right? You say, hey, what's your menu, right? And then there will be if it's a Korean restaurant, a Korean person will be talking from the other side. And then if it's an Indian, there will be the Indian person talking, right? In that way, you could literally gather all the accent right there. And that's very original data. And that's a real data, right? In that context. So I think you can be creative on finding data because there is a lot of data around, but it's like how you want to gather, what kind of techniques you want to think, right? So that's one of the things. Like sometimes you can be very, very creative and find that original data the world has not seen, because I'm calling to the restaurant is I created that data because of my accent, right? There might be something. I just wanted to kind of throw that there.
No, I think it's a good feedback. Just one comment, like what John and Dr. Asif talked about. Days are gone, you build a product and it's sitting on the shelf. You don't do that. Like what John said, ask for the use case, work on the use case, then you will get the customers.
And one other minor point, but it can be an existential risk, is people like to go to large healthcare institutions because they have more data. Large institutions of any type, in any vertical field, healthcare, agriculture, whatever, they become more and more ossified and encrusted and less agile and very difficult. And there's a saying where Muthu and I have worked together that anybody can say no, but nobody can say yes. And so if you find a cardiologist, a dermatologist, or a revenue cycle manager who's really excited by what you want to do, and they get you all amped up and they bring you in and they work with you and they say that they can make this happen, and then their manager says, get back to your business and leave this software stuff to the pros, and you'll get burned. So you're better off finding an enthusiastic subject matter expert in a smaller organization who truly has decision authority, and then you gather evidence that the problem you're solving and the solution you're providing is actually delivering value. You can then go to bigger and bigger healthcare institutions. If you try and eat the elephant whole in one bite, you will choke to death the vast majority of times. So make sure you have a decision maker who is your partner. Make sure that they really understand the problem, that your solution really does deliver results. Because there's a catch-22 with large organizations. They won't buy and deploy something you have until there's evidence of benefit, and you can't get the evidence until you scale to something their size. So do it in smaller institutions. Yeah.
There are folks online, more than 50 plus streaming, but unfortunately you cannot ask questions. Our sincere apologies. Next time we do the panel, you should open up for the online folks to ask the questions also.
Wait, a question.
Yeah, I had a question, but it was around the fact that you said, hey, just go and work with these institutions. How about if you come up with an idea which is actually patient-centric, not organization, hospital, or whatever centric? Then I guess there is also security involved in there as well, right? And I had some questions for. Sorry, I forgot your name.
Me?
Yeah,
Arjun, yeah.
Arjun.
You mean like, can you kind of explain that context a little bit more? Give an example or something.
I think she's asking for direct-to-consumer solutions
Okay.
as opposed to institutional healthcare providers.
Gotcha.
Yeah, and it's a valid question. The direct-to-consumer market outside of healthcare is a difficult road, but there's lots of success stories. In healthcare, direct-to-consumer can be very difficult because you've got all the, and an earlier question referred to the regulatory constraints around making it to a threshold of success. And there's a term called regulatory capture. And regulatory capture is something that large hyperscalers, large institutions actually lobby for in Congress, where they make it so onerous to get regulatory approval that only the big players in the space can afford to jump through all the regulatory hurdles and fund all that. But back to the direct-to-consumer side, you need to be very mindful and have an advisor who's very well aware of the hoops you need to jump through to review what problem you're trying to solve and what solution you're trying to do, so that you don't get destroyed by regulatory capture and the costs that exceed your ability to raise funds. Because there's a lot of great ideas and great solutions that die because they run out of funding in jumping through the regulatory hoops. So it's doable, but make sure you get a really good subject matter expert on the regulatory hurdles you're going to encounter when you go direct to consumer, because they're there.
Yeah, I mean, also you can think like when you're going to BDC, it's like, can you give some advice or service that are not part of like a healthcare? You don't have to be on that regulatory capture, right? You could be like, for example, like if you are doing a well-being app or something chat, right? So you are starting with the thing that could be generic, very useful for the specific group. Once you kind of get that generic, that doesn't apply any kind of like a very specific rules, like compliance, like very light compliance. Then if you really kind of proved your point with it's like MVP. You kind of basically did MVP. It's like, think about the dementia. Somebody has dementia, and you may not wanna be the like a digital medicine for them, but you might be alarm clock or some, I don't know. There might be some creative way to reach out or give one or two things for those kind of group, and then you can figure out that, okay, I found a way to kind of get in that group. Now I can give more service. It's like the company. I forgot, they do meditation, but now they have the certified like the
Calm.
Yeah, I mean Calm. Like there was another company I was thinking. Let's think about let's think about the Calm, right? They started with the meditation; those are generic, but later on it becomes like a therapeutic meditation, right? So in that you can kind of walk that ladder. First, you found that generic solution that is you don't have to worry about any medical thing, and then you kind of walk that ladder. I would say that would be the one.
Any other questions?
Let me add one more suggestion back to, how do you get started as a small startup? One of the things that people don't realize is if you read something from somebody in the field where you're trying to address the question, and you think to yourself, God, I wish I could have half an hour with them, call them, email them, connect to them on LinkedIn, and you'd be surprised. There are a lot of people who remember very well how much they struggled for 10 years of blood, sweat, and tears before they became the overnight success. And so don't hesitate to call people that are knowledgeable in your problem space, and just be persistent, because persistence is a sign of somebody. Jensen Huang was just interviewed about, how did you become so successful? And he said, very simply, I wanted to succeed with far more intensity than the people who wanted me not to succeed. And so when you manifest that determination in how you pursue help by people who are very familiar with the space that you're entering with your problem and your solution set, they will see that. They will recognize that. They will identify with the state that you're in because they've been there. And there's a very good chance they'll help you out for free.
Yeah, but in the medical space, right? Because we talk AI in the medical space. And by the way, I work in tech, but I have no, like, I'm super away from health space. But I have a great idea, and I know it's not been tackled. It's a niche, and it's a real pain. Like, many people want to address that. Like, it's just not there yet. AI can do it, but the problem becomes here HIPAA. So I don't know how do you just go around. This is annoying.
Yeah, I mean, I think the answer to that is you have to find a key opinion leader, an expert in what you're talking about, and then you talk to them. I've had a bunch of this, and I'm like, yeah, that is a pain point, but there's a lot of workarounds, or you're asking a question, but it really needs to be framed like this. So you have to find the person who understands that, and if they're like, oh my God, you figured out something that's just a churn, or it just makes my blood boil every time I have to deal with that, and you solved it. You need an advocate in your company, a CMO or someone who is an advocate who can go to the healthcare systems, by the way, and get them excited. And then you find someone in their system who's going to be an advocate for you, who's going to carry the torch and go to the board and say, this is something that the doctors want. But you have to do.
But it's not the doctors want. See, that's my point. It's not the doctors want. Or maybe they do as well because they're interested in the customer. The patient wants that.
Okay.
So then the focus is the patient, is not the doctors.
I understand that, but still the doctor-patient relationship, it's a B to B to C model anyways. I mean, they have the patient that you're looking for. And it is important to us, by the way, that the patient has a good experience, because last time I saw, there's a lot of doctors around. And if that patient is not having a good experience and someone figures out that problem and gives them that solution, then they're going to go there.
Okay. The problem that I see also in healthcare is that it's not necessarily holistic. So you go to a doctor, and then the doctor doesn't have any idea about what happens in your 20 other aspects of your life, including,
You're absolutely right, 100% correct. And this whole transition from the guild aspect of healthcare professionals dictating to you what they believe is best for you, when you know yourself that that's not a solution that is going to work for you, and you've got a better idea for how to solve your own problem, you're going to get a lot of bad advice from healthcare experts.
So that's why you need AI.
What I would recommend is you go to someone who's had success outside of healthcare, going direct to consumer, and get their advice about how do you do a direct-to-consumer solution, but also get in the opinion leaders who will help you through the regulatory hurdles, through the HIPAA hurdles, and those sorts of things. But if you ask a doctor, how do I create a solution that takes you out of the equation because you're no longer necessary with my solution, guess what they're going to tell you? Okay, so this is not a mystery.
For now, they are still needed because they are the ones who have to just implement that in effectively.
Well,
right?
someone still has to get sued.
Yeah. Oh, yeah.
So the lawyers want to keep the human in the loop. Someone has to be sued. Someone has to own that decision.
Let's talk the rest on the after the thing. Yeah. Anybody else?
Thank you. That was very enlightening. Just is that better? Okay. Okay. Oh, yeah, that's better. Oh, I'm too close to. Okay, I'm gonna have to move. There we go. Oh, okay. Okay, I think we solved the problem. Tech issue here. I think you.
We found the bug.
Right.
Yeah, that's the bug.
So you mentioned about regulatory, and I'm thinking about the years prior to all this computer and AI stuff. the FDA was the one who protected us as Americans, and we had the best regulation of medicine, and which is why we had the best innovation, and it was a good synergy. Now with the kind of defunding of FDA, with that kind of non-science person who's in charge of the Health and Human Services, we're getting away from that. So how do we bring this around? Because this is scary. What you're saying is AI is just marching ahead, and we have a very poor regulatory environment right now that's not scientifically based.
It's even worse than that, because the federal position is no state is able to create their own AI regulatory framework, which makes sense if there were a proposal from the feds about what does make sense as a unified regulatory framework. But what we're being forced into is a completely deliberately unregulated environment for AI, because the states are being told you can't do it, and the feds are not offering anything up, and because of the political polarization these days, not laying blame on anybody, it's just they aren't talking to each other, they aren't working together. So it does, you're correct, the hurdle is higher, because the regulations specifically about AI are going to be applied retroactively, optimistically a couple of years from now if we're lucky. It's going to require a lot of collaborative, compromise spirit that doesn't exist in Washington today.
That's layered onto the lack of
Exactly. Correct. That's why I say it's even worse than you characterized. Yeah, yeah. It's a challenging time. It's a very challenging time. Well, the EU has had a more collaborative environment for the regulatory issues in privacy and some of the approval hurdles, and they have an equivalent to the FDA who has not been disassembled yet. So, you might seek some insight from people who are working there, but if you're implementing in this country, you're still stuck with the dilemma you characterized.
Only one more question, anybody?
So, so we work it out like a startup. Like we have our own startup in healthcare, so it's under mental wellness. So my question is about like, so what is the problem? Like what is the barrier for you when you were onboarding people? Because especially for the patients, not for the medical provider, for the patients, because I understand there is a thing about trust when they're having an AI or some technical, because for obvious reasons. So I understand like having an export validation and having a physical, like a doctor in between gives a proof of trust, like when you get recommended from a doctor. But there are other aspects of creating a trust between the patients and people. So how do you solve that barrier and create a trust between the people when you were onboarding on your product?
Trying to follow the question. Is the question about trust, or is the question how do you onboard patients?
Actually both, because when you create a trust, only then you can onboard. Like, or maybe is there any other way that like Kencor did
All right.
that?
So first of all, JAMA Open 2024 asked patients about this issue, and I also published a paper on mental health and what consumers want. So let me start with that. Consumers want mental health, and there is a lack of access. I talked about a cardiology desert. Mental health desert is, I think, even bigger. So fundamentally, first of all, there is a demand and there's not enough of a supply. So there is an access point that I think AI, especially in mental health, is enormously needed. Number two, I had some notes on this. Patients actually trust in the healthcare system to look out for their best interests. So it's like when you get on a plane, you don't know if it's on autopilot. All you care is you get from A to B. You're trusting on the airlines that they're going to have a high level of security and standards to get you to your destination. You don't get to see in the cockpit. You don't understand how they're doing it. You just go for the ride. Same thing in healthcare. What patients are saying in this JAMA article called JAMA, that's Journal for American Medical Association. So the AMA, big American Medical Association. This is their journal. And they ask patients, you know, what do you think about AI? And what the patient said is they trust the healthcare system that they're going to look out for their best interests and they're going to vet it all. So people like him who the CMO or CIMO of Kaiser, I mean, he's supposed to be the doctor advising that this is the best product for your patients. Yeah, I think I had written this down. You know, key patient concern is the trust gap. And transparency equals trust. And that's why I keep on talking about that. Because, but as far as onboarding, I think that access point, so in general, what Kencor, their model is, you know, I'm tough on my patients. It's tough love. Because I want what's best for them. If you go to my clinic, patients come first, second, and third. I don't care if I get a meal or the only time, and I do not get upset with my staff unless something happens to my patient. So that's why I keep on talking about patient-centric. So as far as onboarding, like Kencor, the patients trust me that I'm looking out for their best interests. And if I say, look, I'll tell you very real. I mean, this is exactly what happens every single day. You go to the doctor, check your blood pressure. If you're like a lot of patients, you go to the dentist or the doctor, your blood pressure is up. So they're in the clinic and they're like, your blood pressure is high. Well, I don't know if my blood pressure at home. Well, we probably need to check that at home because maybe it's white coat hypertension, which means you go to the doctor and you get anxious and your blood pressure is high. So then how do I treat you? I have one data set. All right. So now I'm going to say, well, what I used to do is just give you a piece of paper with blood pressure, systolic, diastolic, and heart rate. Fill this out, send it back to me in 2 weeks. It's not a really great way. You're going to lose the paper. It's just, that's not meeting the patient where they're at. So what Kencor has done is created a easy access. They actually have someone in my office. So I go to, I'm like, your blood pressure is really high. I have someone from this company called Kencor. They're going to give you a blood pressure monitor. Also, very important, there is, have you all heard, I mean, does everyone know what Consumer Reports is? It's like, looks at the best, you know, ranks different devices, what's real and what's not. Okay, well, there is something called validatebp.org, validatebloodpressure.org. So they went through all the blood pressure machines to make sure your blood pressure is accurate. That's what Kencor uses. So they have to go through validatebp.org to make sure that it's there. Number two, to have someone in the office that comes and puts the blood pressure cuff on you and shows you how to take your blood pressure. Now we're talking about digital health literacy. So they literally show you, and then they make you do it. So now you have to put it on, check your blood pressure. And then the third part is you go home with a calibrated, validated blood pressure cuff. And when you check your blood pressures at home on your turf, I get to see what your real numbers are because it comes directly to me. We have a dashboard. The way the dashboard works, if it's green, you're good. If it's yellow, blood pressure could be stage 1 hypertension. Stage 2 is really high. It's red. And so we escalate the reds through a nurse to them to come to me and say, hey, these blood pressures in these patients were high. Let's start a therapy. Because listen, remote patient monitoring doesn't work unless you can show that you're taking these patients from stage 2 hypertension to 1 to normal over a period of time. That is the paper we're publishing to show if you actually give a patient a therapy and they can use it to look at their diagnosis. It's just like a CGM. You eat a donut, you see your sugar spike, and you go, that's probably not good for me. My sugars just went up. And you change your behavior, right? So same thing here. You eat a salty, I don't know, well, I'm from Texas, but my Louisiana guys eat a crawfish boil. Next thing you know, their Kencor numbers were like off the roof. I'm like, this nurse calls them and's like, what are you doing right now? Well, I'm at a crawfish boil. Well, that wasn't really prescribed by the doctor, so it's probably not a good idea. But that's amazing because now I can take care of blood pressures remotely at home on the patient's turf, and that's more accurate than the one time you come to see me with white coat hypertension.
Yeah, on question on enrollment, like what Dr. Asif talked about, trusting the physician. Okay, a physician want you to be enrolling, no cost to you, and we'll be monitoring your health on a day-to-day basis. We have a real-time, Kalyani, she has enrolled 600 patients in the Valley, 3 clinics. I think let her give a couple of examples how she kept enroll patients in the real time, please.
Sure, of course. So, like how Dr. Ali was saying, it's the first trust channel is built when your provider directs you across, and then that is the place where we come into the picture, and then we educate them about how the device works. As with Kencor, we have these blood pressure monitors, which have this SIM card embedded onto them. So with the patients who are pretty much elderly, they have a real-time challenge in accessing and connecting across with the technology. So we've just simplified it across, wherein it just works like any other blood pressure machine, and we go ahead and explain it to them. And not just that, once their device takes in the value, the way the device connects is it searches for a cell tower, and then it uploads it directly to our servers. And while the patient doesn't have to do anything, they don't have to manually go and insert their values or input it inside. That's another challenge that he pointed out, where they don't have to write in the number, email it across to you, just as the old school way. So once we have this real-time value reflected across to us, we know that so-and-so is happening, this is what's happening. And then if the value just shoots up way over the roof, then there's always a coordinator who calls up with them, and then they ask, are you doing all right? You know, are you facing any kind of challenges? We go over with them step by step with our PRO questions, and then we ask them, hey, are you having any dizziness? Are you facing any palpitations? And we know at that point then, you know, this is normal for them, or if they needed to retake it, and if things are going to be fine, or bring in the providers into the picture and triage across with them. So that's how we simplify the process across with them, where you provide the literacy across and make them comfortable, which is an essential step in enrollment, and then provide them. And then we also go ahead and touch base with them a week after to see if they have comfortably settled in with the process and the workflow, and if they do need any further guidance as well.
So healthcare is still high touch and high tech. So we are both high touch and high tech, and our platform is completely reimbursable by Medicare and Medicaid. So that's the other way. There is no cost to the patients, and enrollment will be done easy. Any other questions?
I was just looking at your brochure while you were talking about it, and like all of the blood pressure, the scale, the pulse oximeter, and the glucometer looks very familiar. Yeah, so it looks like it's based in tried and true ways, so I'm just wondering, these are fairly probably not inexpensive equipments. So I'm wondering, let's say if you're in Kaiser. So Kaiser will provide that, and it will link to the Kaiser system where my doctor and my specialists are, and and similar to the
It goes
other
into the
medical
EMR.
system.
Yes,
It goes directly into EMR, so we can make those decisions. Yeah.
Oh, fantastic.
Yeah, it's a cellular device. We are sitting next to a product engineer, and our VP of engineering is back. They have tested hundreds and hundreds of devices, all the devices, and we have 99.99%. and we have KOLs like Dr. Asif to validate this is the right. In fact, today he got a goodie bag for our engineering team of the blood pressure cuff. So that's very important, and we all of them are FDA approved. Even the the weighing scales are all FDA approved product. All right. So just to wrap it up, last final thoughts. This is my personal question, nothing to do with this. How AI in healthcare, if somebody touched on it, if I'm a patient, how do I see AI is going to make my life easy, if at all it's going to make one? How do you think, your last thoughts on that? Because we talked enough on the provider side, hospital side. We touched on patient, you touched on patient side of it, but I would like to get your opinion on that.
I mean, human computing is very important. The whole concept of digital health literacy is very important. I'm glad you said these things look familiar to you, because if they look foreign to you, you're not going to use it. And then the stickiness of the platform, because you get real time and you get real feedback from real people who are looking at this, keeping the human in the loop. I think those are all very important, because you get a phone call from a human, not an AI agent. And then that gets reported to the doctor. And so the last kind of part of this is called shared decision making, that both the patient and the healthcare provider are in unison on something that there's a good return of value first. And yes, there's a return of investment, but we're not dinging the patient for the cost. We're saying that there's a cost savings, or else Medicare and Medicaid would not cover this. So there's a big enough cost savings by giving this away free than not, because the alternative hasn't worked out. And that's why we have RPM and CCM. Thank you.
One last question, I think. You want to comment on this?
Yeah, I mean, it's generic comment. I think, I mean, it's like a little bit looking forward when there will be more and more adoption of agent in the hospital system. I think that then that will be a very interesting story, right? Then we're like, you may not have a direct touch with doctors even. The doctor might have like orchestrator in some sense. So you are being a little bit further. So if you had a doctor appointment every month, now it might be every 5 months, because the 4 months there are agents that are somehow regulated and then kind of like orchestrated in some ways. So I think there might be, in that way, there will be agents involved in our life. So the cost gonna go lower and lower. It's like measuring your glucose from home, right? Because of the digital things. Now, I think right there now, what happens is we need to really think about even governance, because now it's not the HIPAA may not be enough. Or like the SOC 2 and all those kind of may not be enough for organization. You need to really think about the agent-specific governance.
And also data sovereignty.
Oh, yeah. So it's like how agent are using that on your behalf. Sometimes it may be talking or reporting. You might have an individual, your agent, health agent, that might be just without your, you gave a permission. So without your direct touch, it inferred in contacted doctor or contacted like a person. How do you really govern that? I think that's a very interesting thing we're gonna see evolving down the road. It's a very exciting from the security and governance part.
Thank you, sir.
Yeah, sure.
One last quick question.
So I have a mental wellness startup called Happiness Factors, and the reason we were advised to call it wellness instead of health is because then we don't have to go through the HIPAA compliance and other stuff, and being a startup, you don't have money to go through all the stuff till you get the funding. And so my question to you is, like, there are several companies, like, for example, Kaiser. They use mental wellness apps for their patients because it costs them less than to have someone see someone in person. So how does mental wellness or any other app which is not that much certified by HIPAA come into picture if you are a doctor and you have to prescribe it to a patient, and the company might have already bought that particular app or that particular solution for the patients? What do you think about that? Like integrative medicine or something else?
Yeah, I mean, you can definitely go down to integrative medicine. You just can't make claims,
Yeah.
and you have to keep it in wellness. So look, I mean, I think there's a very gray zone from the consumer who doesn't understand. It's not that they don't understand. The consumer is collecting data, so that could be wellness data.
Yeah.
And now you have medical devices like we have FDA approved only devices. And so I think but the consumer doesn't see, even on devices like Apple Watch, some of it's FDA approved, some of it's not. I don't care if you have a Fitbit and it is off by 200 steps. That is not going to make me change my decision. But it does matter if your blood pressure is 20 off or your heart rate's 40 off. That's a problem. So, yeah, I mean, it depends on the user case of what you're trying to find. If your app is dealing with someone who is suicidal, I would say that is not the right app for you. If your app is something where you're trying to do an SF-36 to improve how they feel and their quality of life scores, that's a different story.
Like stress management, burnout,
things like that, yeah.
panic attacks.
And there's plenty of those. Thank you very much for having us over today. Thank you.
Thank you so much. It was very, very informative. Thank you.
Thank you for coming. And folks on online, we're just going to wrap it up. And I think stay tuned for the next panel, and we will let you tuned in through social media. Thank you. Thank you all.